Good morning, everyone. We are delighted to see so much interest in this topic. Martina, who is helping us today with the Zoom, has indicated that over 150 people have registered for this event. Let me just say first to the Healthcare Authority being willing to do this session. We find ourselves in difficult times because we've worked with the Healthcare Authority a number of years and we consider them to be trusted partners. However, in full disclosure, we know that the Healthcare Authority has been tasked to come up with a Medicaid managed care plan, and they are very mindful that the Oklahoma Hospital Association and our members are in opposition to that plan. However, that being said, the agency has to move forward as if it is going to happen. And clearly we know at the end of this session, we're going to know one way or another what's going to happen next. But this much I will say, regardless of which side prevails on this topic, we will still have to work together regardless. So I want to let you know that up front, because this isn't about time to debate the merits of whether or not the state should move to managed care or not. The purpose of this, quite simply, is to go back over the preprint approval process on directed payments and making sure that you understand the implications for your hospital. I know a good number of you have had contracts given to you by managed care companies. I know that you're trying to figure out what you're going to do, but we know regardless, if this plan should move forward, you need to have a full understanding of how directed payments are different than SHOPP, and they are different. And so with that, I want to also say on May the 12th, we are also hosting a meeting with the Healthcare Authority regarding Medicaid expansion enrollment. So very clear, regardless of whether or not managed care moves forward or not, we will be starting an enrollment process come June 1st to begin eligibility on July 1st. So we would like for you to dial into that so you can also be prepared to understand how that will work. And Medicaid expansion moves forward regardless July 1st. So let me just go back to just the mechanics of this presentation. Not only is Aaron Morris, the CFO of the Oklahoma Healthcare Authority, we're also joined today by Jimmy Witkowski, who is the Director of Financial Management, and they will be doing the presentation. It will last approximately 10 to 15 minutes, and I've been told that as you have questions, please type those into the questions field, and they will attempt to answer these as they come up. We will also have time at the end of the presentation for questions. So with that full disclosure, and Aaron and I have had conversations like this in the past, as we have with Director Corbett. Aaron, the floor is yours.
Thank you, Patty. Appreciate that. I think you covered off the mechanics of it pretty well. So yeah, just to echo that, we're going to have a pretty brief presentation, hopefully give you a lot of good information, a lot of detail, but want you to have the opportunity to ask as many questions as you need to ask. Hopefully we'll be able to answer most of them. If not, we'll get back. Just again, a welcome to everyone. Appreciate the interest, appreciate you joining us. We are going to focus on supplemental payments, or the SHOPP program, and how it will be impacted by our move to managed care. But just again, appreciate you guys joining us and the interest. Martina, do you want to go ahead and show that presentation? All right, so focus is SHOPP today, but before that, Martina, if you want to go to the next slide, we will go ahead and just give you a kind of a foundation of here's where we are, because as Patty said, a lot of big changes with the Oklahoma Medicaid program coming up. And our first one is expansion. It comes on July 1st. So student care expansion, also known as Medicaid expansion, a vote of the people, a constitutional mandate. Oklahoma Healthcare Authority has been preparing for this for a while now. We were preparing last year, so we feel like we are ready to roll out. We have some specific requirements in the mandate that we are going to execute on. So eligibility criteria for expansion, adult ages 19 to 64 that don't already meet some medical criteria that would qualify them for a traditional expansion population today, and income is 138% or below of the federal poverty level. Patty mentioned application process. This is really important. It will begin June 1st. We have kind of started spreading the word, but we'll rely on our partners to do the same. So folks will be able to apply beginning June 1st, and we will evaluate those for eligibility to begin on July 1st, where our coverage for the population begins, and that's really our go live. I do want to note that we do believe we'll be able to kind of ramp up enrollment pretty quickly. A lot of that is due to just the data we have currently today. We have folks that have come in and applied and been denied because they don't currently meet a traditional Medicaid population, but they would fit into expansion. So there's an opportunity for us to potentially recycle those applications. We have our family planning program that has many of these same Oklahomans in that program that we can move to expansion, and some other programs that may also be impacted. So we do think our enrollment will ramp up very quickly. And as such, we've contemplated that in all of the supplemental payment processes that we've done for this year. Benefits under expansion will look just like they do for current sooner care traditional adults or parent caretaker population. So we just want to make sure that that's understood. That's a process that we go through with CMS, our federal partners, to make sure that there's alignment between the benefit plans. Next slide. So next is, of course, our Sooner Select program, which next slide, please, is sorry, you're already on there. Our Medicaid managed care program. You guys know all about this. We've been getting out, talking about managed care for a while now. We've done, I think, 5 town halls, and we'll continue to hopefully answer all the questions that there are. This will take effect October 1st, 2021. And the populations that are impacted are children, including our kids in custody, low-income parents, we call them parent caretakers, pregnant women, and adults age 19 to 64 that we just spoke about, our expansion population. So there's, it's going to be an interesting educational process for us with the expansion population specifically, because they'll be going into expansion and immediately be looking at electing a managed care plan. So that process is ongoing, and we'll start that communication and education process soon. A note, all medical and dental plans are required to have statewide coverage, so no regional plans. We would encourage you to communicate and hopefully contract with all 4 medical plans and 3 dental plans. Next slide, please. So our partners on the medical side, Blue Cross Blue Shield of Oklahoma, Humana Healthy Horizons of Oklahoma, Oklahoma Complete Care, which I believe is a subsidiary of Centene, and United. On the dental side, DentaQuest, Liberty, and MCNA. Again, all statewide plans, no regional plans. So I guess what we're all here to talk about is SHOPP, and so let's talk SHOPP. So I guess I'll start with SHOPP has been an extremely successful program. We definitely understand that. It was implemented in 2011. We know our hospitals rely on it. It will continue. It'll just be split. So there'll be parallel programs on the fee-for-service side and the managed care side. Sooner Care SHOPP will continue for non-MCO populations. It'll look exactly like it does today, just be a smaller pool of funds, because we'll be breaking off those folks that go into managed care into what we call it, or what is called, a directed payment program. And that will be for our MCO populations, including children, pregnant women that we spoke about earlier, and expansion adults. Combined, when you put these two programs together, it will make, what currently makes up SHOPP today. And when I say make up, I'm talking about the funding levels. They will be very similar to what you see today. Of course, trended forward like we always do, measured based on the UPL like we always do, and then adding an expansion population that is, we're making assumptions that is pretty significant increase to the UPL. Next slide. Here's just a quick graphic that we put together to kind of show some characteristics of the programs and hopefully do a quick comparison for you and help you understand how they align and how they don't. Just again, once the decision was made to move towards managed care, one of the first things that we thought of and we knew is supplemental payments had to be preserved. We have to make it a point. It has to happen. It's too big for us not to. So our intent always was to preserve the level of funding through supplemental payments, and as much as possible the structure of those supplemental payments. CMS gave us approval on March 31st for our directed payment program. That I hope it doesn't get too confusing, but we'll continue to call it SHOPP. We'll just refer to it as fee-for-service SHOPP and MCO SHOPP. But CMS did approve that, and we believe that we've achieved that our initial intent, our purpose of keeping the program whole and maintaining the integrity or the structure to the greatest extent possible. So I'll go through these line items and talk about the similarities and differences quickly. So federal authority, and this is just our authority to make a payment. We have to get that from CMS because, quite frankly, they are the biggest investor. They pay, somewhere between 60 to 90%, depending on our enrollee and depending on the year. So on the traditional side, we go through a Medicaid state plan. We've had authority since 2011 with very, very small changes. And on the managed care side, it's what's called a section 438.6C preprint. Again, that preprint was approved on March 31st, so we do have the authority to make payments in a managed care environment. The payment type, it's just a naming, supplemental payment on the fee-for-service side and a directed payment on the MCO side. I think directed payment just is exactly how it sounds. We are directing the MCOs to make payment to hospitals. These are what are called separate payment terms. So they're not part of the base, they're not part of the capitation, they're paid outside of that process. The pool categories was really important. We wanted to make sure we didn't change the integrity or the structure of the pools and make our smaller hospitals compete with our larger hospitals. So we are maintaining that we'll have a private and NSGO pool, both on the inpatient and outpatient side, and then a separate critical access hospital pool, much like we do today. So not any changes as far as the pool, as far as that's concerned. The critical access hospitals will still have their pool established based on how it is today, based on their cost, a little different payment structure and how it's distributed. But again, it's going to end up very much the same way. The annual assessment it'll be based on statute and based on your hospital cost report data. So net patient revenue from the hospital cost report. We will use the upper payment limit to determine the assessment rate, just as we do today. So no change expected there. There could be some changes on the invoice. We still plan to do one single invoice, but there may be line items there. But as we develop that process, we'll communicate any impacts or changes to you. I want to stress that these are both utilization-based programs. So we are always looking at hospital utilization to do allocations. We have to, it is a federal requirement, and that will continue. The real difference here is instead of in our fee-for-service SHOPP program, where we're looking back to a prior fiscal year and projecting forward for a kind of a set flat payment, the distribution for the directed payment program will be based on the prior quarter and tied to utilization. I guess I would call it a little more reactive. So utilization changes change the distribution more frequently than they have in the fee-for-service program. Some I think that will be a great thing. Some may have some nerves about that, but we really think it's very similar to how we do today, just a little more reactive. And then payment frequency. Today we pay 5 times a year, really 4 with a withhold that we pay out at the end of the year. In the directed payment program, that will change slightly as we'll pay for even quarterly payments. I think the last one here is the fixed payment pool. And again, we will establish the pool for the programs the same way. We'll use the UPL as the establishment of a fixed pool. And then we'll split that out into a fee-for-service portion and a managed care portion based on their distribution of the gap. On the fee-for-service side, you won't see any change. It'll look just like it is today. On the directed payment side, you won't see any change, but I do want to make sure it's understood that these payments are not at risk. So that pool will be spent by the healthcare authority. We won't retain any of the funds if utilization decreases or whatever impacts happen. We will just increase the percentage of the supplemental payment that's paid out to hospitals. So I guess for distribution type questions, I know we've had a couple. I'll try to give an example. If hospital A, if their utilization stays the same and the pool utilization, the other hospitals in their pool utilization stays the same, obviously the distribution is the same. If their utilization increases and the rest of the hospitals in the pool utilization stays the same, they get a greater share. If all hospitals distribute or all hospitals utilization increase or decrease at the same level, then again, your distribution is the same. So again, fixed pool distribution changes based on utilization, but I think you'll find that the result is very much how it is today. So just a few more points before we move on to the next slide. I wanted to highlight for a claim to be considered and to be evaluated for a supplemental or enhanced payment, it has to be a claim paid by a plan that the hospital is contracted with. It's really important. I can't stress that enough. We can't evaluate claims that are paid by a non-contracted hospital or paid to a non-contracted hospital. So again, we encourage you to reach out to all 4 plans. We encourage you to contract with all 4 plans in order for you to maximize your revenue potential for Medicaid and us to be able to have a full set of data to analyze and review and pay out based on. Second one is, I think I said it already, but these are separate payment terms, separate from the base capitation rate that we will pay to the plan. So OHCA will own the evaluation of the encounter data. We will own the analysis and determination of payment amounts, and then we will push that to the plans and direct them to pay it to the hospitals within a certain time period. So again, separate payment term outside of the cap process, or not outside of the cap rate, outside of the cap rate and process, but will still be directed through the MCOs. Number 3, I'm gonna really stress the importance of billing quickly, especially in the first quarter as we're ramping up. I think it's going to be really important for hospitals to get claims in that quarter, so we have enough data to evaluate and really pay we're going to pay the pool, but we need to be able to say that this is a reasonable amount that we're paying above the base payment. So I will encourage the plans and stress the importance on the plans of paying quickly, which we're doing anyways, and we have in our RFP a 14-day pay requirement. But I'll just stress here that you guys get those claims in that first quarter specifically. So we have a full amount of claims to evaluate. And if, it's based on paid claims submitted in the quarter or paid claims during the quarter. So, if one hospital has a lot of paid claims and you're lagging on your billing, it could impact you in that first quarter. And last, the payments will be in a lump sum. That's our plan. We are going to direct the plans to pay out in a lump sum, just like you received today. So the real difference will be, instead of one payment from Oklahoma Healthcare Authority, you get 5 from Oklahoma Healthcare Authority for the fee-for-service side, and then 4 plans paying you for the directed payment side. So just 4 important notes I wanted to make. And Martina, you can go to the next slide. Okay, so this is a visualization of the process. I know some people probably don't need it, but I did, and it was really helpful to me. It just helped me kind of picture and understand, how the process works and how the flow will happen. So the left side, you see the regular reimbursement process. That's the base payment. And simple enough, inpatient or outpatient claim, services rendered, inpatient or outpatient claim filed to MCO, and then MCO returns the payment and pays the claim. On the right side, you get into the process after the end of the quarter on the directed payment side. So the MCOs will share encounter data with OHCA. We'll receive that weekly from each plan. The assessment will be due just as it is today, the 15th day of the first month of the quarter. And I'm making some assumptions that statute for SHOPP doesn't change substantially. I know there's likely some changes coming to incorporate part of this process, but we're going to do our best to maintain the structure of the program as it is today and have as little interruption as we can. And then OHC analyzes that encounter data, as we've talked about. We will send a report to each plan and then direct the MCOs to pay hospital, which hospital and how much to pay each hospital, and ask them to do that within 7 days. Next slide. So this is the exact same process. So a little bit of duplication here, but a different way to visualize it. And it's just an added note. I know people look at things a different way, so we created 2 just to say, whichever one makes sense to you. I think the first one is the one that has kind of triggered with most, but willing to share either process if there's one that works better for you. So I think that is, I think that covers what I wanted to talk about today. Again, a couple of notes. We did get approval, so it's there. I know Patty's probably shared that with her members. So we've tried to get the word out as much as we can. We are approved to make these payments. There are some slight variations to the current SHOPP, but again, our goal was to preserve the level and structure to the greatest extent possible. And I think we've done a really good job of that. We want to work with hospitals. We want to understand their questions and concerns, and we think that'll also help us develop our processes and procedures as we move forward to operationalize the program. Jimmy and his team will run it just as they've done in the past. He has a great experience with SHOPP, so he understands it as well as anyone. We'll be doing some testing after the first month to make sure that we are ready to evaluate and ready to and able to make the payments timely. And our goal is really to put the timing in the same, in a very similar fashion as it is today, as to not create any cash flow concerns for hospitals. So right now we pay within 10 days of the assessment due date. Our intent is to keep that time frame very close, if not exactly the same. Now, I'll stress, our need for you guys to be timely on your assessments, and I think Jimmy's told me that hospitals are doing a really great job of that in the last couple of years. And we had some problems for a few years, but not too many lately. So, but it's going to be important for us as well. We're going to try to do right by you and make this work for you. Hopefully you guys can also be timely with assessments, so we're not running into cash flow issues that could impact our operations as well. But I think that's it. So I'll start looking at Q&A, and Patty, Jimmy, and I will run through these and hopefully be able to answer any questions that you have. So Jim, will this presentation be shared with OHA or the participants? I will get with Martina and see how we could, make this shareable. I know she's recording, so I'm sure there's a way, but I'll ask her as after we finish this one. Pregnant women includes a soon-to-be centers program. It does not. So soon-to-be centers is outside of the, soon-to-be centers is for pregnant women, but it will not move to Sooner Select. I think that's probably the question, but it was carved out of the managed care program, along with TEFRA. There's a couple smaller programs that were carved out, and I don't have those in front of me, but if you have any other questions on programs, I can respond to those. I'm not sure I understand the question from Richard Wagner on the blackmail plan, so I will, Martina, you can dismiss that one. Let's see. Please explain what happens if a hospital does not contract with all 4 health plans. So hospitals would still be able to negotiate as a non-contracted provider to receive the base payment. However, they would not be able to participate for that claim in the directed payment program distribution. Will there be a reconciliation at the end of the 3 quarterly DPP payments are made? So there will be a reconciliation after each quarter. And since we're doing it based on paid dates, there's no planned end of year reconciliation. CMS will require us to, our actuaries to reconcile some of the actual payments to make sure that they didn't vary from our initial expectations. So that process will happen, but there's no plan for end of year reconciliation, since we'll be doing quarterly reconciliations and not paying off based on estimated amounts. All right, Shasta asks, please explain the claims can be only evaluated for contracted facilities again. So you have to be a contracted provider with a managed care plan to participate in the directed payment program. Now, if you contract with one of the 4, then your claims for that one plan, paid by that one plan, will be in the pool and part of the analysis for distribution. If you contract for the other 3, they would not. So in order to have all your claims evaluated for the directed payment program, you would have to be contracted with all 4 plans. I think that's important, as we are requiring all 4 plans to be statewide. So you will have patients, regardless of where they live, likely participating in all 4 plans. So you will have to be a part of all 4 plans in order to have all of your claims in the pool for distribution. Tim, if the MCO distribution is based on utilization from the previous quarter, does that mean we wouldn't get a payment for fourth quarter 2021 since there is no MCO data from the previous quarter to base it on? How do you get around that? So I think you mean the fourth calendar year quarter of 2021. We basically, what this is doing is pushing payment from a kind of a current period payment to a future period payment. But what we're going to do is we're going to build up, if you will, the fee-for-service part for that last calendar quarter. We've modeled that out. We believe that we can do it under the UPL and hold everybody whole so that pushing of the directed payment program to a future quarter does not result in any budget or cash flow issues for hospitals. So basically, you could say that we're paying for that quarter twice, that last quarter twice, but we feel like, we will have the gap for the fee-for-service part that would be sufficient. Plus, how that quarter is going to roll out and, how many claims will be owned by fee-for-service, how many claims will be owned by MCO, that's difficult for us to project. So we feel confident that we can make the full SHOPP fee-for-service side payment and hold that calendar year or hold that quarter whole. Jay Johnson, where does the authority for requiring a contract to count as a Medicaid day come from? Is this a choice OHC can make? And is it written in the RFP? Is this a CMS regulation? This is a CMS regulation, Jay. It's in the federal reg pre-grant guidance that it must be a contracted hospital, or it cannot be, or it must be a participating, I think is the word they use. I did follow up with CMS to ask that question to make sure that this was not an OHCA option, and they confirmed that it must be a contracted hospital. What is the time frame that MCOs will be expected to make the SHOPP payments? Shelley, we're planning 7 days or fewer. That's our target. It won't be more than 7 that we will require that payment. Will provider need to be enrolled in the state fee-for-service plan to contract with an MCO? Yes. They'll start from, our base contracting, and they'll use that group of providers to build out their network. Aaron mentioned the town hall meetings that have been conducted. I'm sure I missed something, but would appreciate understanding what was discussed and how Mercy can get caught up. So Jim, we've went to, let's see, Kingfisher, Woodward, Duncan, Poto. I think I'm forgetting one. And we've also been to, had one in Oklahoma City. These town halls are just general information about our transition to managed care. We try to answer some frequently asked questions, but we also have a panel available to answer questions from attendees either in person or online. And we're putting out some information on those town halls through our Twitter, our Facebook accounts, and other social media. I don't know that they're being recorded and posted for playback. They may be, but there likely will be more. So if you follow those accounts, our Oklahoma Healthcare Authority social media accounts, you'll see those that are coming and where they are. And even if you're outside of that area, you'll have an opportunity to view online and answer or ask questions then as well. Can you put the last slide back up or forward slides? Martina, can you? So this is a part of the process, or another way to visualize the process and how and who's responsible for what piece. So happy to answer any questions on that as well. So Tim, assuming Senate Bill 131 goes through, will directed payments still have to happen, or will the entirety of SHOPP return to normal? That's a question I haven't really considered, Tim. I'm not really sure I have the answer to it and how an internal managed care structure would have to happen and what authority it would fall under. So we'll have to come back to that one. Patty mentioned it in her welcome. Our job is to execute and we are moving forward and executing and building our ability internally to do a third-party managed care program. So that's where we're headed, and we're focused there. What kind of oversight will the state exercise over the MCOs, primarily with denials management? 14 days to pay on a clean claim is great, but I've experienced delays with other states' MCO plans when it comes to clean claims. Michael, we're building those processes now. Of course, we will require a significant amount of reporting from our plans. We will also be tracking encounter data. We're actually, engaged in the process of our building our reporting manual, building our processes and procedures and our policies for our oversight arm. We're also building up our staff for our managed care oversight team. So we'll do our best to share that information as we get it. But that's a big one for us. We understand that we are a fast payer. Probably the biggest benefit to our providers from Medicaid. We pay fast and we're good at it, and we're going to have that same expectation of our partners. Does the RFP define the geography required to constitute a Medicaid market? What is the mileage requirement to determine a viable network exists? Jay, that's a really good question. And I want to be able to answer all these questions, but we might be straying a little bit outside of my expertise. There is a mileage requirement in the RFP. Trailer knows that like the back of his hand. And I'm afraid that I'm going to say something that's not accurate. I'm about 50-50 on whether I know the actual mileage requirement. But yes, it does exist. We will require heat maps. We will have to understand that they have an adequate network before we go live, and we'll make sure that network adequacy is met. Sandra Harrison, how will you determine utilization? I'll do my best here. Utilization is paid encounter data. So plans will be obligated to share their data with us. If there is a paid claim in that time period, just as we do today, we'll evaluate it. Has there been any modeling done to show estimated impact to hospitals? So this is a really good question. And the way I visualize this or look at it is, our best model would be our SHOPP model. That is our model. Distribution changes may happen based on utilization changes, but we can't really go hospital by hospital and say, here's what their utilization is going, how it's going to change in the next quarter. So our best evidence and how we budget and how we plan is based on historical data. It's the same way that we are analyzing SHOPP. So our best model is the SHOPP model. Now, if we're talking about the distribution between a directed payment and a fee-for-service payment, yes, we've done some modeling on how much goes where, and we've done a hospital by hospital. So if we could find the right format to share that, I think we would be willing to. But we want to make sure it makes sense to everybody and it would be, valuable, because it does require quite a bit of time on Jimmy's side to make sure that that's, accurate and we're putting out good data. From Warren Spellman, while I understand OHCA wanting us to contract with all four, I would like some comments from them and OHA on how they can justify contracting. Yeah, Warren, this is kind of outside the scope here. And again, we're kind of getting into an area I didn't really want to move to in this conversation. There will be opportunities for us to discuss, and there has been the merits of managed care. And I'm not really sure that that's part of this conversation. There's still only one assessment from OHCA. That's correct, Tim. OHCA will still collect the non-federal share through the provider tax There will be one assessment. Like I say, we believe we'll handle that through one invoice. There may be multiple lines on that invoice. Sandra Harrison asks, what is the payment rate if you're not contracted out of network? Sandra, in the RFP, I believe the cap is 95% for non-contracted. I think the language says 95% or as agreed upon by the parties. So well, that is definitely in our RFP and available online. If we don't contract with all 4 MCOs, will auto assignment in our market still assign to non-contracted MCOs? Yes, auto assignment will assign. And again, all MCOs will have to operate statewide. So auto assignment will not take into account region. Are you aware that requiring us to contract with all 4 MCOs in order to receive SHOPP funds will significantly hamper our ability to negotiate terms with the MCOs? I know that's definitely a potential impact, Doug. It's a federal reg that we really cannot get around. It's not a state option, not an OHCA choice. That one is federally required. Merrick Morgan, just make sure we will have 2 SHOPP programs, for one for fee-for-service and one for directed payment program. That's accurate, Merrick. We'll have 2 SHOPP programs. I know the how we describe them and the language that we use could get confusing, but it will be 2 supplemental payment programs, 2 SHOPP programs. Really the way I would say is SHOPP fee-for-service, SHOPP MCO. One will be a supplemental payment program through fee-for-service. One will be a directed payment program through the managed care delivery system. How will the SHOPP assessment change? For example, with April through June 2021 invoice, our hospitals roughly 5% of the assessment was for SHOPP expansion. Roughly how much will assessment break down for July 1 through September 2021 traditional Medicaid versus MCO? So July through September 2021, you will not have a MCO portion. How this will break down, I think, is in that detail of, what's the split of the UPL between MCO and fee-for-service. I know we have that, Stephen. I don't have that in front of me, but it's something that, Jimmy, you might be able to speak to this better than I will. We will ideally break that out on the invoice, and potentially we could share that prior if we believe that that's valuable information for our hospitals. In aggregate, it should be, just as we've always done, but as far as a breakout between what portion of the assessment will be used for expansion, what portion will be used for traditional, what portion will be used for MCO. I think that's information we have readily available. Is that right, Jimmy?
Yeah, and technically it won't show up until the January invoice for MCO. And, right now we're kind of unsure how long the public health emergency is going to extend to. So that can factor in a little bit. So for the current calendar year, we're only doing fee-for-service and expansion assessments.
Yeah, hopefully we answered that, Stephen. If you need follow-up, let me know. Will direct payments come from MCOs to providers be dependent on profitability of the MCOs in any way? No, Lynn, it will not. That's part of that separate payment term. We will be directing with a dedicated pool of funds the MCOs to pay a certain amount. They will not be at risk for those payments. Will the OHCA require the plans to utilize the member's Medicaid number as the plan's member ID for reporting purposes and tracking? So we will have Mitzi, we'll have we'll have to have logic to intake that and match it to a Medicaid member. I will have to talk to our team whether that will be a requirement of using a Medicaid ID, an MPI. We have various ways of matching those claims to, or matching those members to members. We do it with Medicare today. We do it with third parties. The process will just have to be built into our data sharing arrangement with the plans. Can MCOs charge a processing fee for our directed SHOPP payments? Jay, are you asking if the MCOs can charge the hospitals? No, they should not charge the hospitals a processing fee. We will pay a small administrative fee for those, but they should not be charging hospitals. And I think I missed one. Rick Wagner asked, will there be any settlement of the old cost report rate used for payment into the plan, and directed payments out using last quarter volumes are different? There will not be any settlement. I mean, we're mismatching time periods in our current SHOPP program. We have cost reports. We use the most recent available. So we have cost reports from varying time periods. That process will have to continue as we can't just always match time periods. Reconciliation, this isn't really a cost-based payment, so reconciliation to cost, I'm not sure I follow there.
Yeah, and I would also add right now under current SHOPP legislation, we only update the cost reports every 2 years. So that assessment is stuck at the same cost reporting period and is only updated every 2 years.
Lisa asked, will each MCO have different prior authorization processes? We have some specific PA requirements in our RFP. Processes, likely yes. They will have their own prior auth process. It won't all come through the agency. I hope I answered that one, how you were asking. Jay says, if we don't contract with all MCOs, will our non-contracted MCO days count towards our 340B Medicaid day thresholds? Those are still Medicaid days. I don't see why they would not count towards that. They would still be reported on your cost report, still be on your DISH reports. So still Medicaid days, just non-contracted hospital. Debbie Brewer, you may have answered this question, but we are having sound issues. If a hospital elects to not contract with any MCO, it is my understanding that we'd be paid 95% of fee for service. So HCA decided that those payments can't or won't be calculated in order for a hospital to receive SHOPP. So OHCA has to follow federal reg that says a hospital must be contracted with a plan for the claims paid by that plan to be counted for a enhanced or supplemental directed payment. So on the fee for service side, of course, that doesn't apply, but on the MCO side, yes, you would need to contract with the hospital or with the plan for those claims to be considered and factored into the allocation process. The 95% is in the RFP, but I believe the language is a maximum of 95% or to be determined or as agreed upon by the two parties, the contractor and the provider. I believe that's how it's worded. Have you directed the MCO to pay at least the current Medicaid rates? We've left that fairly open for MCOs. We have certain provider types or services that we have directed the MCO to pay a minimum fee schedule. For most, we're allowing that negotiation to happen between the provider and the hospital, or I'm sorry, the plan and the provider. Hospital, that would be a contract arrangement between the hospital and the plans. So that is all that's open in the Q&A. Let's give it a couple minutes. Merrick Morgan asked, have you given thought to an ACR for the DPP? And yes, we have, Merrick. I think it's definitely an option that we'll consider in future years. In fact, in our current preprint that was approved, we put a maximum of the average commercial rate in there as kind of to make CMS feel better that we wouldn't go, crazy, but also it gives us an opportunity to move in that direction. I think one of the limitations that we've seen from ACR type UPL arrangements or other arrangements is data. If we felt confident that we could get the data, then I think we would definitely look at pursuing something like that. And one note I didn't make, but I should have, and is, this Patty talked about the partnership with the Hospital Association and the Healthcare Authority, and we agree 100%. We've partnered on a lot of programs and just had discussion on pretty much everything hospital related in the past. And we did the same here in development of the directed payment program. Hospital Association was very involved and integral in making this an approvable document, and also just making it in a way that would be good for hospitals as well. So we appreciate that partnership, and we'll continue that. And if all parties agree that an ACR is how we want to move, or if we're able to move in that direction, we'll definitely look at that. I assume that expansion patients will have the ability to choose their plan. Not all will be auto-assigned. That's correct. And that's, again, a federal regulation. They must have choice to a certain extent. I believe it's in the initial enrollment. They have an open enrollment period. If they don't choose, we will auto-assign. They'll still have 90 days to choose whether they want to change plans or not. Merrick Morgan, most facilities have to report their commercial information for CMS. Yeah, I don't know that we could get that data from CMS. We would certainly look into it. We've never gone down that path before for hospital information, but that sounds great. And if hospitals are already reporting it to CMS, that means they could likely send the same reporting to the healthcare authority. So it's definitely something that we would be open to. So I think Rick doesn't have a question. He has a comment. So appreciate the comment.
Well, Aaron, if
Yeah.
there are no further questions, do we want to wrap up, and will you be providing instructions how our members can get a hold of this PowerPoint? Because given the passion and the questions asked, it's very clear there's a lot of lack of understanding. And I want to be implicitly clear, Aaron did invite us to participate in language in the directed payment program to try to make it as good as it could be, but it is not the same. And we thought it was very important to understand the contracting process, but in absolute transparency, the agencies on one side of moving ahead per the governor's direction. The Oklahoma Hospital Association is not endorsing this. This is clearly, we would like to see Senate Bill 131 prevail. So we're going to continue to do what we have to do on our side. They're going to do what they need to do on their side, but I want to be crystal clear about that so that there's no lack of understanding on any of our members' part about where we stand on this issue. Because I know we will get questions. I know, Aaron, you will probably get questions on this. I would like to really see that we have this recording available, that we can also hand off to those that have not been able to participate today.
Yeah, Patty. I appreciate the comments, and yeah, we'll work with Martina to see what we need to do to make this available, as well as the PowerPoint. No problem on the PowerPoint. Just need to make sure I know what we need to do on the Zoom. So, and just want to make sure that all the hospitals know that Jimmy and I are available. If you wanted to have a follow up, if you needed to have, you know, if we needed to set aside some time to discuss directly any questions or concerns or data needs, we're here, we're available. Our email addresses are very simple. It's our first name dot our last name at okhca.org, and that's consistent throughout the agency. So reach out, and glad to have this meeting today. Hopefully answered some of your questions. I know there's probably others, but happy to spend some more time if we need to. So thanks everyone for attending. I don't see anything outstanding, so I think we can adjourn. Thanks, Patty.
Thank you, Aaron. Thank you all for dialing in. I know there's more questions, so thank you all for your interest. We know this is important. Thank you.